like Dr. Fried said, my presentation today is, it's not really a catchy title. I didn't want to make it a bit shorter, but it's Venipuncture and BP Cuff measurement contraindicated in the ipsilateral arm of a previous mastectomy for those who don't have a history of lymphedema already. I have no disclosures. Small outline, I'm just going to talk about a scenario about lymphedema in general, venipuncture, blood pressure cuff, a small survey that I took in the previous week, what our protocol is at the hospital, and then we can discuss sort of the results. So let me show you a scenario that happened to me when I was an intern. You get a 52-year-old female, distant history of breast cancer, status post left-sided mastectomy. She comes in febrile, right-sided costovertebral tenderness. She's tachycardia, she's tachypneic. She's got a dirty UA, and you see this on her right arm. So she has a fistula on the right, and so you go to take a blood pressure cuff on the left, right? And then somebody runs up and places this limb alert on the left-hand side and says you absolutely can't take a blood pressure on that side. It's contraindicated. And so then you kind of say, well, where do we take the blood pressure? And the answer is sometimes the leg, maybe sometimes the wrist. It depends. But that's why I thought this was an interesting subject to talk about. So this is kind of just a graph of the lymphatic system in general up in the axillary area. You have sort of 5 major parts. You have the pectoral, apical, lateral, central, and posterior nodes here. Lymphedema in general, it's just the interstitial collection of protein-rich fluid. It can happen with disruption of lymphatic flow, and basically the lymph load exceeds the transport capacity of the lymph system, which causes filtered fluid to accumulate. But breast cancer-associated lymphedema is more so, it occurs secondary to either disease or treatment of the breast cancer, and that can be surgery, radiation therapy, and it also can occur from obstruction of lymph channels, nodes, or infiltration with tumor cells. So this here is kind of a slide discussing lymphedema, kind of the patient's history, if they're more likely to have it for certain reasons, BMI over 50, parent has lymphedema. But something I found that was interesting is on physical examinations, there's something called Stemmer's sign. Has a sensitivity 92% to predict lymphedema, only a specificity of 57% to exclude lymphedema. But it's basically, you can do this on the finger or the toe. You kind of take it, you bend it back a bit, and basically if you can kind of see a wrinkle, it's most likely not lymphedema. If you can't, could be lymphedema, but really the best sort of diagnostic practice is using lymphoscintigraphy to really tell. This is kind of the stages of lymphedema, 1 through 4. 1, kind of no visible edema or swelling, almost barely perceptible, and 4, very visible disfiguring edema. So. And the idea is basically that patients with surgically removed lymph nodes have a compromised lymphatic system, and they can't effectively clear the fluid, and they end up having this resultant sort of immune response, and it leads to more buildup of lymphatic fluid in the arm, causing lymphedema. There's been a lot of studies on this. It's kind of, this was a really good paper I found in 2020 discussing the pathophysiology behind lymphedema. Basically, 2 main principles that they think to be happening. Adipose tissue remodeling, so they have hypertrophic fat lobules that compress and collapse lymph capillaries, and it results in fluid and lipid transport disruption, leading to further fat accumulation. This is not great because the adipose tissue remodeling leads to dysregulation of adipokine production, metabolic stress, low-grade local inflammation, and it ends up increasing secretion of pro-inflammatory cytokines that promote more immune cell infiltration. This isn't good because you also get fibrosis and lymphedema, which is just a lot of deposition of extracellular matrix. And they see that as it lays down, the collagen accumulation in the subcu fat causes this tissue to harden. And that's why we don't get that pitting sort of look in lymphedema versus other types of edema. And all these collagen fibers cause further sclerosis of the vessels, which increase smooth muscle cells and collagen fibers, showing loss in their ability to transport lymph fluid and can cause more lymph leakage. So why is this so worrisome in general? You know, we obviously know it can cause disfigurement. Some less know that it can cause, chronic pain and swelling, recurrent infections, decreased quality of life. But a big thing that I think not a lot of people know is it's a big source of biomedical expenditures. There was a really good study I read that showed that there's more than a $10,000 increase in annual treatment costs of cancer survivors who end up having lymphedema versus those who never had lymphedema. So it's quite a financial burden. And right now we really only have symptomatic and palliative treatment. There's no cure for it currently. So we'll kind of get into some of the older papers and studies, and why is this still so propagated as an idea in a lot of nursing, PA schools, etc. So basically, kind of one of the papers that have the first reported case of breast cancer-related lymphedema associated with needle punctures looks like it's Villasor in 1955. And it was discussing many risk factors, and they included in it venipuncture, which can lead to lymphedema in women who underwent radical mastectomy. There wasn't a whole lot of factual statements explaining why needle puncture can cause it. It was kind of grouped in with a lot of other sort of information. I was looking at a couple of other papers too. 1992 is one of the most noted sources of avoiding needle sticks for breast cancer-related lymphedema, including, this is from Brennan et al., and there's really been no known clinical trials demonstrating causal association between venipuncture and breast cancer-related lymphedema. There's many other papers too, and there was a great review article going over these and kind of why they're not the greatest of papers. Can discuss a couple of them. 1955, they had basically a study where they had 51 patients with and 28 without arm swelling, but they only saw one patient to develop lymphedema after venipuncture, and 3 patients developed it that they stated was aggravated after venipuncture. But it was found that infection really accounted for the majority of lymphedema in 16% of the patients, and no explanation was given if this is associated with venipuncture or if this is more due to infection. There's another paper in 1962. They reviewed 114 patients with lymphedema after radical mastectomy, and basically they acknowledged that the extent of surgical removal of the lymphatics was the most important factor, and that they added in that venipuncture should be avoided, but it was an unclear relationship to venipuncture. It wasn't exactly described. A couple other papers, 2006, 2009, very similar, that they put venipuncture it should be contraindicated in the ipsilateral side, but these 14 patients with the axillary node surgery, none reported swelling of the limb within 2 months, and when they ended up auditing them, they thought that they actually wrote that use of the ipsilateral arm for cannulation versus the contralateral one is problematic, it's not appropriate. And we just see a lot of this echoed out throughout the years. Every 10 years or so, 5 to 10 years, there's been a couple of papers stating really similar things without any factual backup to it. And I think a really good explanation of this is the mastectomies that they previously did, even 20 years ago, is a lot different than kind of how they're treating breast cancer nowadays. So it was a big post-operative problem, but a lot of oncologists believe that it's most likely due to the invasive nature of the axillary treatment that they had previously. Also before, they managed women with breast cancer with more general-based surgeons, and now they're more carried out by breast-specific surgeons. Nowadays, fewer patients undergo axillary clearance, and those who get this sentinel node biopsy have lesser degrees of disruption to the lymphatic architecture, so it is very surgically based. And there's a wide range of sort of central venous delivery devices now that are less invasive, like PICC lines that are used for these patients. I kind of like looking up what other countries are thinking about this sort of idea and what the recommendations are. This is from 2015. A couple of different recs from the UK, Mayo Clinic. Some say it's okay to use the other arm, but preferably use the contralateral side. Some say absolutely not. And so it's kind of like a scattered opinion right now. But basically, when I was looking through papers, there was a really good one in 2016 from the International Society of Lymphology. And they were discussing all this long list of do's and don'ts of what to do with the ipsilateral arm after mastectomy. And they really explained that a lot of these sort of papers were largely anecdotal. They're not sufficiently investigated. There are some really good precautions that rest on solid principles, such as a BMI greater than 25, causing an axillary node dissection and radiation of the axilla, are pretty factually based in how they can cause lymphedema. But standard use of some of these don'ts for risk reduction, such as never use blood pressure cuff on that arm, never use venipuncture on that arm, they're not really steeped in a lot of facts, and they can subject patients to sort of unsupported therapies. There also was another really good study I like, Naranjo. They basically had almost 8,000 IV placements, and only 4 had complications. And it was interesting because 2 of them had complications in the ipsilateral side of mastectomy, 2 of them had complications in the contralateral side. So the frequency of complications was found to differ significantly between the 2 groups. A couple of other papers, Kilbreth et al., they had this prospective cohort study where women who had breast cancer were recruited prior to treatment. They were followed for 18 months. They kept diaries. And in their study, they showed needle punctures only had an odds ratio of 2.0, but had a wide confidence interval, so it provided little direction. Ferguson also had a good study between 2005 and 2014, and they had 3,000 measurements, 3,000 patients, and they showed no significant association between the volume change or the weight-adjusted change in the arm after IV venipuncture. And so, this one recommendation I found recently from the American Society of Breast Surgeons expert panel, they basically say that the use of ipsilateral arm for IVs or blood pressure measurement after breast surgery with axillary node removal, it's not contraindicated, but let me be clear, this is for people who have not had lymphedema previously. There's no specific recs for patients already diagnosed with lymphedema, whether or not they should get blood pressure cuffs or IV draws on that side. And it would be probably better to exert more caution in those settings. But after discussing with some of the oncologists here at the hospital, they agreed too that a little bit more cautious, but it should be fine in those who have not had lymphedema previously. When it comes to blood pressure cuff measurement, there was a little bit less studies and papers, but it seems like initially, this was first noted in 1920 from a paper from Drury and Jones, who basically hypothesized that increased venous pressure resulted in the lymphedema from the blood pressure cuffs. There was another paper that's frequently cited from Petrick, who thought that blood pressure monitoring, tight bands, tight clothing, things along those lines, increased lymph production, and it could cause fibrosis and stenosis of the lymph vessels, creating obstruction of the lymphatic flow. And a lot of other authors seem to echo out these sentiments throughout the years. But right now, there still is no solid evidence to support blood pressure cuff measurements will increase lymphedema despite these long-term fears. There was a physical activity and lymphedema trial. It was a prospective randomized control trial in 2009, and they sort of reviewed multiple different do's and don'ts for lymphedema. They basically had 3,000 patients. They showed no significant association between sort of lymphedema size change or gaining lymphedema after the fact of after blood draws or injections. And then Showalter ended up doing a sub-analysis of this study to examine the relationship for blood pressure cuff monitoring. And they found that it was not significantly associated with incident arm swelling. And they measured at 3, 6, 12-month follow-up appointments. Let's see. And so, this is all really interesting. It's still kind of happening right now, but I guess the question is, so just use the other arm. What's the issue? Outside of the scenario that I painted for you earlier. Bilateral mastectomies are becoming more and more frequent. A lot of people are getting these contralateral prophylactic mastectomies for unilateral cancer. There was a paper by Tuttle who ended up looking at the sort of epidemiology and end results of this, and there was a 162% increase in the contralateral prophylactic mastectomy from 1998 to 2003, and 188% increase for non-invasive disease too. But basically, this is from surveillance of breasts, plastic reconstructive efforts, suspicious family history. It ended up peaking around 2013, and then it slowly started decreasing towards 2020. And that's what's on this graph here. But I think it's important to note that this still leaves like 10 to 15 year time span of large amounts of people who had bilateral mastectomies that could be coming to Cottage or any other hospitals. And it's something to really consider when we're taking blood pressure measurements or we need to get IV access, ABGs, et cetera. I also like to see how this relates to our hospital. I don't like to just talk about things that are not pertinent to us. So I did a small survey, again, like last year, and it was about 30 respondents, mainly in the ICU and ED. And I basically asked, is it okay to put a blood pressure cuff on the arm that had a previous mastectomy? And 72% said no. I said, okay, well, can we put an A-line on that arm? Again, 72% said no. And then I said, is it okay to place an IV? And about 58% said no, and 16 were kind of like, I don't know. And if a patient had a bilateral mastectomy, I asked, how would you take the blood pressure reading? I kind of put in a fill-in option, and 62% said the leg, 17% still said the arm, so they thought it was permissible. 8% said leg or arms, 4% said ankle, and 1% said, I don't know, ask the patient which arm they've been told to by their physician, which that's all right. That's a good answer. And then I gave them candy for answering. So the policy at Cottage here, they discussed the limb alert, this pink wristbands that I showed you on the first slide, that it should be placed on an arm if they previously had or if they have a fistula, a mastectomy, lymphedema, DVT, et cetera. It should be assessed, look in the medical record, and then put a limb alert on it. And I discussed with multiple charge nurses and other nursing facility, how do you guys kind of determine who gets the lim alert exactly? Who's asking, or what are we seeing in the chart or anything? And I was told by multiple, which may not be representative, that they basically see if there's a fistula. They ask them, if they've had a previous mastectomy, or they'll say it sometimes, and then they'll put the lim alert on, and that's about it. And then we see it as they come up to the hospital and they're on the floors and everywhere else, and we kind of take it as gospel. They got a lim alert, don't touch their arm. And a side note about some of this, taking BP in the calves, ankles, legs, things like that. I was looking up some studies on this, and usually it's 17 higher systolic blood pressure when it's taken in sort of the calves or legs, unless they have peripheral artery disease in a lot of the patients that we have. So it's not exactly super accurate. Could be detrimental even to their healthcare if we're not taking accurate blood pressures or able to get IV access. Could subject them to, placing IVs in the feet at other hospitals. I don't think that happens here at all. But the bottom line, I really like this quote from this lymphology paper. It said, with peripheral lymphedema, rigid practice parameters and excessive warnings may raise patients' fears unduly over such minor events such as taking blood pressure, blood drawing, and air travel, and interfere with medical surgical interventions. And I really like this because as breast cancer mortality falls, there's growing numbers of women who are going to be living with the effects of these surgeries. They're going to be status post-mastectomy, and I think that there's a wealth of advice available to these patients regarding how to reduce their risk of lymphedema. But I think that we need to be cautious about how we make our recommendations and really take person to person on a case-based scenario, maybe discuss with their oncologist if they're present or available. But I think total avoidance of IV catheters on the arm, ipsilateral, the breast cancer surgery, as well as blood pressure cuff isn't needed in general as an overarching rule, especially for patients without a history of previous lymphedema. These are my references.
Okay. Well, I guess we'll just open it up to any questions or discussion. Anybody have any comments or questions? Dr. Bordowski.
Just to start off, that was excellent review of the literature and exhaustive and very impressive presentation. Kind of as a little aside in the beginning, you were talking a little bit about lymphedema in general and some of the pathophysiology. And I was just a little bit curious if you'd, based on some other information I read about a condition that is similar to lymphedema but thought to be grossly underrecognized and common, called lipedema, which is, I don't know if you read anything about that or...
I lightly perused. It does seem sort of similar. It also seems really complex, like they are still trying to figure out the exact pathophysiology behind it. But I think the combination of sort of adipose tissues and fibrosis is in the similar vein, not to make a pun, but.
Yeah, I mean, from what I recall about it, it's more of an inflammatory condition with a lot of edema in a more gynecoid presentation, so people may have massive edema in their arms, yet a very small amount of edema at the waist and in the legs, but often associated with a lot of pain and inflammation and grossly underrecognized, and even associated with hypermobility, neuropathy, and I had heard also responds well to a low carbohydrate diet. It's interesting, and I've never heard anybody bring it up.
Yeah, I agree. I think that is a point also very similar that they were making in many of these papers, that BMI is such a significant portion of developing lymphedema, and I think it's very hard to tell, have somebody bring down their BMI, but it's a little bit easier to say, well, just don't put a needle or a blood pressure cuff on that arm. But I think it's a really under-recognized sort of lifestyle change that maybe should be, I guess, further implemented when it comes to worry for lymphedema on that side and for
Not
lipedema.
related to the topic you were doing, but just as a side.
No, that's great.
One of the pathophys.
Yeah.
Thank you.
It seems like a lot of the story, a lot of the improvement was related to the surgical techniques improving.
Yes.
Did you do any reading of is it that they're doing dye-related kind of sentinel node techniques, or is there anything else that we can know about what got better?
Yeah. So I won't pretend to know the intricacies of surgery, but it seems like, based off of what I've spoken with other oncologists, that they are just removing less nodes now, that they're able to do a more precise sort of surgical removal, and just coming down from the large scale mastectomies that they were doing in the 70s, that has improved sort of lymphedema in general, that this was such an overarching problem prior to adjusting those surgeries, and whether that's because they have breast cancer specific trained or breast specific trained surgeons versus general surgeons, or it's just the technique is improved in general. Either way, it has definitely reduced a lot in the last 30 years.
When I was looking through some of this stuff, I noticed an article that was just published a few days ago. I can't remember which journal it was, but they had said that in certain patients, they're not even doing sentinel lymph node. They did a trial to see whether they even needed to do sentinel lymph node biopsies on a subset of breast cancer patients with small breast cancers. I can't remember the size. I didn't read the whole paper, but they found that there was no difference in mortality rates several years out in that select group of women. So I think it's even that's becoming less common.
And then so my question back is it actually just a myth or a truth, or is it actually that women who had mastectomies prior to some year that these surgical techniques got better actually ought to be regarded as different than the more recent mastectomies?
I definitely think it should be considered when discussing all of this. There's a lot of factors to think about of the reduction of lymphedema, and I do think the surgery getting better is a really large portion of it.
I think this is kind of a classic myth. I think one of the things I love about these presentations is when they can go back and find out where this all started. And this has been going on for at least 70 years, it looks like. They've been saying this based on just a couple of case reports, really. And even those case reports were kind of suspect, some of them. So, this is the generation of a true medical myth, I think. But that's my personal opinion. I think this is classic. So thank you. You did a great job. Okay, so I think it's time to vote. This is the statement: venipuncture and blood pressure cuff placement is contraindicated in the ipsilateral arm of a patient with a previous mastectomy for those with history of lymphedema, without history of lymphedema, excuse me. How many people think this statement is true? How many think it's plausible? How many think it's busted? So, bust or no bust? Bust.